Welcome back to Medical Monday. I have Dr. Ben Lin here with me answering tons of questions about skin tonight. It's all about your skin. That's the topic. Dermatologist down in the Cool Springs area. We've got a ton of questions, but I don't want to avoid our Facebook friends here. Jack Lance wrote in about surgery for excessive sweating. I haven't heard of a surgery. What are your options if you have excessive sweating?
Yes, so first of all, when you have excessive sweating, the dermatologist should try to figure out, is it due to any underlying health conditions, or is it what we call idiopathic, which means that it just happens and it could be genetic. Some of the common areas where people sweat excessively could be the armpits, it could be their palms, it could be the soles, it can be the face or other parts of the body. Now, when I talk with patients about excessive sweating, I tell people there's a stepladder approach to treating excessive sweating. You may want to start off with the most simple thing that can be done, which is the topical application of prescription aluminum chloride. If that doesn't work, then we move to the next step on the ladder of treatment, and that may be the use of Botox injection, which is FDA approved to treat armpit sweating.
And why does that work?
So it's interesting, but Botox does more than just relax muscles, because we typically think of Botox as being used on the face to help with facial expression lines caused by our muscles of the face. But it also blocks the production of sweat from the sweat glands. And so when you inject Botox, let's say in the armpit, the results can last up to a year at a time for individuals.
Wow.
So it can be very durable. Obviously the downside is going to be injections, as well as the cost of doing the procedure, because a lot of times it's not going to be covered by insurance plans. The next level of treatment may be with oral medications, and typically we'll use oral medications called anticholinergic drugs that actually also block sweating from all parts of the body. When used properly, it can work very well for people who have multiple areas of sweating, where it's really impractical to use a topical product or to use also Botox injection. Then you have surgery, and surgery is, there are different levels of surgery. You can certainly use a device now called the MiraDry, which is using microwave energy to surgically destroy sweat glands and ducts in the skin. And then a more invasive type of surgery would be called sympathectomy, which is where a surgeon would actually go in to the thoracic spine, or whichever level of sweating that you have on the, let's say, the armpit or the hands or the feet, and they cut the sympathetic nerve, which is responsible for leading to excessive sweating. The problem with that is that there are surgical risks that comes with it, because when they go into the chest wall cavity, you may get a collapsed lung, may get an infection. And then the other thing that's also very troublesome is that you can get a compensatory sweating elsewhere. So that means he may cut a nerve that will lead to ending the sweating of your palms, but then another part of your body
takes
compensates over and then sweats a whole lot more. So that could be problematic.
Okay, good to know on that one. Jack, thank you for your question very much. Terry also wanted to know, he has very thin skin, and sometimes just working in a shop or just touching his skin, it looks like a blood rash. What can cause this?
So we see this very commonly in people over time as they get older, but also people who've had a lot of sun exposure over their lifetime, because actually that also leads to thinning of the skin when there's excessive sun exposure. When you have those factors combined with the fact that people may be taking medicines to protect the heart, such as a low-dose aspirin, or they're taking ibuprofen that's used to treat arthritis-type pains. Those are blood-thinning medicine. If you drink some alcohol, that's also blood-thinning. If people take some supplements, such as St. John's wort, ginkgo biloba, those things actually also thin out the blood. So little trauma will cause the capillaries in the skin to rupture more easily. Then you get these purplish patches on the skin. And one of the troubling things with that for a lot of people is that over time, the blood that leaks out of those capillaries will stain the skin, and then we start to see a lot of discoloration in the skin from the blood products that leaks into the skin.
Yeah, I think we've all seen that on people. Okay, let's jump back to the phone lines. We have Andy. Andy, thank you for calling in tonight. What's your question?
My question is, I have skin cancer. It's not melanoma on my cheek. And how many times can you freeze it before you need a Mohs procedure?
Wow.
A interesting question. So let me explain for the audience what he means by Mohs procedure. Mohs micrographic surgery is a technique for the removal of skin cancer with margin control to make sure that you've removed it completely. It was named after Dr. Frederick Mohs, who developed that technique, and now well-trained dermatologists do use that technique to treat skin cancers in high-risk areas. And high-risk areas would be, for example, around the eyes, around the nose, around the lips, around the ears, and even on the cheek, because those are areas where the skin cancer can actually grow along what we call embryonic fusion planes, where it can spread more widely underneath the skin. Now, if your skin cancer was previously treated, let's say, with excision with margins before, but they did not clear it, then that would definitely be a reason to consider the Mohs micrographic surgery technique to make sure that you have margin control. And what's different about Mohs micrographic surgery than regular excision is that when the site of the skin cancer is worked on, the tissue is processed while the patient is still in the office, and 100% of the margins is looked at by the Mohs surgeon to make sure that there is clear surgical margin before they stop. With regular excision, when it is sent to the pathology lab, usually only about 20% of the margins are looked at and read out as being clear or not clear. So because you're not examining 100% of the margins, then you cannot actually guarantee that you've got it all gone.
So when you're done, when you're doing this procedure, you can guarantee that, okay, we got the cancer, it is now removed.
Right. Success rate with that is going to be like 99%.
And I think that Andy said, how many times can you have something frozen off before you need to have this Mohs? What do you tell a patient?
Yeah. So typically in my practice, we do not freeze skin cancers. The best way is going to be some surgical technique if people are good surgical candidates. And when I say good surgical candidates, it would also mean that it's someone who is healthy enough to undergo surgery, as opposed to considering other treatment options for skin cancers, because for example, now with basal cell carcinoma, if someone's not a good surgical candidate, there is now an oral medication that people can take to actually cause the basal cell carcinoma to regress and go away. There's also radiation, also as a treatment option for people who are not good surgical candidates. But whenever possible, you want to have surgical removal with margin control to make sure that the cancer, once it's taken care of, it's gone and you don't have to deal with it again.
Yeah, absolutely. Andy, best of luck to you there. Let's hop to Debbie. She's been waiting a while. Debbie, thank you for your patience. What's your question tonight?
Yes, what are the options for facial aging?
Good question.
Wow,
all of us want to look youthful and at our best. So where do you start?
Right. I think the foundation of helping with aging skin is always going to be good photo protection, which we kind of addressed a little bit earlier by saying you always want to use sun block with SPF 30 and above. A second thing that has good scientific data to support it is the use of tretinoin, otherwise people know it as Retin-A, that if used on a daily basis, it actually over time will help reverse some of the visible signs of aging, such as blotchy skin, fine lines.
What's the I'm going to interrupt you real quick. Difference between Retin-A and retinol?
So retinol is a precursor to Retin-A. It's not as quote-unquote strong as Retin-A, which would be by prescription.
Okay, gotcha.
So a lot of people may start off with retinol because their skin may not be able to tolerate a higher strength tretinoin or Retin-A product. So they start off with retinol. And in my practice, what I like to do is gradually build people into be able to use tretinoin or Retin-A.
Okay, so that's supposed to reverse the signs, is what you said.
That's right. That's right. Now, in terms of reversing the signs of aging, it all depends upon where you're starting from. Because if you're starting later and you have a lot more obvious signs of photoaging and aging in general, such as wrinkles, such as poor skin color, where you can have brown splotches, redness, you can have enlarged pores, skin that doesn't look as healthy, it looks more sallow, then you need to look at more aggressive things such as medium to higher strength chemical peeling of the skin or laser resurfacing of the skin. And with laser resurfacing of the skin, there are now two categories of resurfacing. You can do what's called ablative resurfacing, which is where you're really stripping off all the layers of the epidermis and part of the dermis, and you're causing people a controlled second-degree burn, and you allow new skin to come in. So that's a lot more aggressive. Or you can do what's called non-ablative resurfacing, where the laser energy enters the skin and it causes a wounding underneath the skin that causes the epidermis to actually slough off, but there's no open wounds, and that treatment actually is much easier on the patient in terms of recovery time. And again, a couple of dermatologists up at Harvard developed this type of non-ablative resurfacing that is called fractionated non-ablative resurfacing, and people may recognize the name of Fraxel because that's something that has been the buzzword for many years, and they were the leaders in that technology.
You know, I think Rebecca called, I think it was Rebecca said, you know, let's talk about downtime with these different lasers. And I don't think we got to that before. So whether we're doing the full Monty of the, you know, the big shebang, or we're going with the less invasive one, what kind of downtime are we talking about? Where you kind of got to stay inside, or people are going to say, what in the world did you do?
Right. So if I can share with the audience, you know, pretty much every laser that or energy device that I've had in the office, I've used on myself. And so we do distinguish between what is truly downtime versus social downtime. And social downtime is time in which you may not want to be in front of the public eye just because you may not look as good, but it's not truly downtime because you have no raw open skin. So if you're going with a procedure, let's say for example, for helping with wrinkles and dyspigmentation of the skin, and you're going with a non-ablative laser, the Fraxel, and I've used that on myself, the typical social downtime is about 7 to 10 days, and it's very predictable. If initially your skin will look more reddened and a little bit more puffy, like you've had a sunburn. By day 3, the skin is going to feel rough, like sandpaper, and what you're seeing there as little dark rough sandpaper skin is actually the epidermis that's been destroyed, so to speak, by the laser energy. And then over the course of 7 days from that, it just naturally sloughs off. There's actually no true downtime. When I've done it on myself, I've even gone out and just played golf the next day. I wouldn't advocate that for for my patients, but I've done that just because I know that's very safe.
Gotcha. Okay, very interesting. We're learning so much. I hope you're enjoying this and getting your questions answered. We're going to have to take a quick break. When we come back, more of your questions. Stay with us.